Good morning. This is Erin with the Department of Medicaid. It's not quite 10 o'clock, excuse me, and we're still clearing the waiting room, so we'll give it just a few minutes before we get started.
Thank you, Aaron.
Good morning, John. The waiting room is clear. I currently show yourself, Dennis, and Brandon logged in. Did I miss any TAC members coming in?
I did not see any other.
Okay. Would you like to wait a moment longer to see if we have anyone else join us, or would you like to go ahead and start?
We can give it 1 or 2 more minutes just to be on the safe side.
Absolutely.
Thank you.
You're very welcome. The waiting room is still clear. You do have a quorum with 3 if you'd like to proceed, or we can wait a moment longer, whichever you
You can
prefer.
go. You're going to get started. Thank you.
You're very welcome.
So, good morning. Welcome, everyone. We
I'll
have.
have to fix the
I'm
speaker
sorry.
so you can hear.
Are
I
we
think
okay?
we're good to go. I think someone just wasn't on mute.
Oh, okay. Thank you. So quorum has been established. Our meeting minutes from our last TAC meeting, did everyone have a chance to review those? And if so, did anyone have any questions, corrections, changes? Hearing none, may we have a motion to approve the minutes from our previous meeting?
Brandon, I move to approve.
And I'll second, John.
Thank you. So all those in favor?
Aye.
Any opposed? Okay, let's move on to our old business then. We have the update on procedure codes and impact on reprocessing.
Hi, this is Veronica Judy Cecil with Medicaid. I'm hoping that there's a DMS staff member on to provide an update on this. Just pausing for a moment, and my apologies if we were not prepared to discuss this.
Okay.
Hi, this is Kelly Kitchen, the branch manager for healthcare policy. Can you advise what procedure codes are in question?
I have to go back to my notes and tell you that.
Mr. Chair,
Yes.
this is, for the record, this is Steve Hoagland with the Primary Care Association. If memory serves, I believe this had to do with systematic updates that had occurred, that we had received there had been reports from participants or members of the association that after the code sets had been updated, that some of the MCOs were requiring a resubmission of claims as opposed to reprocessing whenever the systems were updated. And I think there was a question about whether or not that was also occurring within fee-for-services system with Gainwell. I think that had been resolved, but I think it was just maybe a follow-up in kind of understanding how that was being handled by the MCOs whenever procedure codes were updated. What is the expectation for that?
Dr. Holland, did that have to do with some of the modifiers? Am I remembering that
I believe
correctly?
it did. I believe it
Okay.
did. And also procedure code updates as well as fee schedule
Okay.
updates that were occurring.
Yeah.
Unfortunately, I don't have my notes from the last meeting in front of me either. I'm going off of memory, which is always a dangerous thing.
Dr. Hoagland, if I may, yes, it was, the fee schedule was recently updated, and I think it was around that fee schedule and the addition of the new telehealth codes
Okay.
primarily, yeah.
Thank you for that. Thank you for that. Okay. Then let's move on to the next one, beneficiary consent to communications. No update there?
I don't believe we have an update on that either. I'm
Okay.
sorry.
That's okay. No apologies. And then we have update on the potential changes to the MAC and tax.
I can do that one. As a reminder to folks, a federal rule made changes to the framework and structure of a Medicaid advisory committee. We currently in Kentucky have, and the rule did historically required an advisory council on Medicaid medical assistance, and we have that in our statute. There's a state statute on that to be in compliance. That rule, that new federal rule changed the federal requirements. So we are working to be in compliance by July 9th, which is the effective date. The way we are doing this is we were unable to pass legislation to change the state statute to comply and align. So we're going to maintain the membership in the state statute for the new Medicaid Advisory Committee. We've added additional representation as required by the federal rule. We did an application process, and we have received those applications. Those are being reviewed, and we do anticipate we are on track with making those appointments by July 9th. We'll post the new MAC membership list once that's been finalized. We'll send it to the TAC. Once we make those appointments, we'll send all the TACs that list. This also means, just as it relates to the MAC, that the meetings of the current advisory council that is being changed, will be canceled. There were a couple of meetings already set up throughout the year. And then we'll schedule a new meeting cadence based on the availability of the new members of the MAC. So so just know that the ramification, kind of the impact to you all will be if you make a recommendation. The procedure is the MAC has to hear that recommendation and approve it. That'll have to wait for the meeting of the first new MAC. We anticipate that to be in September. And one of the first things we'll be doing once we make the appointments is working with those new members on what's a meeting date that works for them. So we'll get that out as soon as we can. So maybe a little bit of delay in the response to a recommendation. We are going to try to be very collaborative with the TACs during this time. There was one TAC that wanted to make a recommendations. We let them know about this. It could be a couple of months delay. And so they elected not to do a recommendation, but just make an informal request to us. It's something we're happy to take back and something that we could do without a formal recommendation. So that's just an example of how we're trying to work with the TACs on it. So the new federal changes do not impact the TACs at all. So the technical advisory committees will keep meeting. They're still in state statute. There is no change to that. And then the brand new beneficiary advisory council, that is also part of the federal rule. We have taken applications. This is brand new to Kentucky. Other states, there's a handful of states that already had a beneficiary advisory council. So we've got a lot of great lessons learned, best practices, and there's been a lot of help from CMS. They issued some guidance and some best practices for states. We did an application process for them as well, and we are going through those applications, and we are on track for making appointments to the Beneficiary Advisory Council by July 9th as well. The Beneficiary Advisory Council has to meet before the Medicaid Advisory Council Committee meets. So now we're going to be having additional meetings of the BAC, and 7 members of the Beneficiary Advisory Council sit on the new Medicaid Advisory Committee. So that's part of the new representation on the MAC. So we'll be having a BAC meeting, and then we'll be having a MAC meeting, and then we'll be also having our TAC meetings. So lots of meetings, but like I said, we're very excited about the BAC, having that much representation of our population. It's both former and current beneficiaries, and there's representation from parents, guardians, caregivers on that BAC. And we're really happy to see an increase in that representation on the MAC as well. So we'll keep you guys posted. Definitely will be sending you the membership list once we get the appointments done. I do want to note one thing about that. The federal rule allows a BAC member to withhold their name from publication. So once we do appoint these BAC members, we'll be reaching out to them, asking them if they're okay with sharing their names. So that might look a little weird if we have a list, and we're just going to have to list, BAC member number 4 or something like that to give them that option. But I'm happy to take any questions if there are any about what the changes are that are coming.
Thank you for that explanation, Veronica. Appreciate that.
Yeah.
Appreciate that. I thought I had read something about a BAC, but I wasn't clear on what that meant. So I appreciate that explanation.
Oh, you're welcome.
Thank you. Were there any questions from that update? Okay, seeing none, let's move on then. Excuse me, to new business. KPCA updates. And Dr. Hoagland, can I ask you to, are you going to be able to represent the organ? Okay.
Yeah, I am. Thank you, Mr. Chairperson, members of the committee. Good morning. Our CEO, Molly Lewis, sends her regrets for not being able to attend today. She is attending a meeting in Washington, D.C. with her counterparts from other primary care associations around the nation, at a meeting that is being held in conjunction with the Bureau of Primary Health Care, the administrator and administrators of that department. I think it's still called that, under the agency that was formerly known as the Health and Resources Services Administration. So again, she sends her regrets. I think that this is a good opportunity to get some updates on what is happening, you know, in other primary care associations around the nation, but it also get some insight into what is happening within the Beltway. So that just means that you're stuck with me this morning, and so my apologies for that as well. So I wanted to take a few moments to give an update on what the association has been working on for the last several months. And we have been, as member organizations do, you need to spend a lot of time understanding what is impacting your membership. And this committee is very aware of a lot of those implications. This is, or a lot of the events that have been transpiring both on a national level, a regional level, and a local level. But, you know, for our guests and others that are invited, providing a little bit more of an in-depth update, thought would make a lot of sense. So as part of that, we have been conducting a listening tour, trying to understand what is first and foremost on the minds of our members. In particular, given the scope of this committee, taking the lens of how does it, what is impacting delivery of services to Medicaid recipients, is, so I'm going to narrow the kind of the breadth of that listening tour to more of that. There are several things that kind of come up in common that I want to put out to begin to address. One is that there has continued to be concerns brought forth by members. And I would also say, you know, as part of our listening tour, we've heard from other like-minded groups and providers. And we've also been able to reflect back on data that is available to the association now, based on its position as an organizing member of a network that has implemented a data aggregation tool, pulling in information both from EHRs of participants, but then also getting payer data. And so we can look at things at a more aggregated level today. So from that, we have seen and heard that there is an ongoing concern around the ability to engage patients that are assigned or attributed to provider groups, and then also at the network level. We believe that's driven by a number of things. I won't unpack all of those, but some of it starts from the very beginning of an individual gaining eligibility for Medicaid. There's other steps that occur throughout, but at the end result is that there are tens of thousands of patients that our groups are expected to interact with, where we have no information coming across on eligibility files. Many of those patients have never been seen by our groups. And so that creates a very challenging position. We understand, and from that listening, it creates a very difficult challenge in trying to engage a patient where you don't know where to reach them. And you know, I think this is something that you hear in other states, and there's not a simple solution, but continuing a process to try to address that, I think, is extremely important for our providers, for the mission they have, also to help support the common interest that we believe exists, truly believe exists with the managed care organizations as well as the department, the cabinet, and the Commonwealth of Kentucky. It's really hard to move healthcare measures if you're not able to get people into your doors. So that's one important thing that we have continued to hear and work to address through this process. And I think that helps form some of the backdrop for the next item. And that is an item that we have continued to hear about variations that occur within the different administrators of Medicaid benefits as contractors to the Commonwealth, and specifically related to value-based purchasing opportunities. There is a great recognition that the efforts of both the managed care organizations and the department have been recognized and felt. However, there still feels to be some opportunities to streamline some things so that the end result of patients, of their members, our patients receiving the services that they need, the preventative services they need, still exists. And we do feel that is the ultimate goal, obviously. In particular, the efforts that the department put forth a few years ago in having a common incentive program, a value-based purchasing program for the MCOs to operate under, has been helpful. And as expected, that the expectations that the managed care organizations have from the state are being passed through to providers, and that's a logical extension. However, underneath that, there still remains a wide degree of variation that we hear our providers experiencing, and we also have seen through some other means. Candidly, admittedly, the variation on the measures that are of interest have lessened. The variation of what is considered to be success has not necessarily changed to the same degree. And so the way that the health plans are setting expectations for what is attainable or achievable continues to be fairly widely variable from one health plan to another. And then whenever you get down to the methods that are being utilized, the operations that are used under each of the programs, the variation becomes very wide. And our concern is being that the differences create the opportunity for confusion, which introduces the opportunity for error, which makes it less likely that ultimately patients are getting the preventative services that they need, that providers are able to engage the patients in the way that they would like to, and that the department and the Commonwealth are not seeing the value that they would want. So we want to continue to look for ways of getting recognizing that there can be some valid reasons for variation, that where there is opportunity to get something that is more streamlined, that is more replicatable, to get the results that we all want, something that we would encourage, that we think through on a more global basis. It's easy for an organization or individuals to make assumptions. We tend to do those things. One of the things that we have encountered or experienced in different conversations is the difference between the macro view to the micro view, and that's often in the eye of the beholder. The reality is that for the membership of the association and the network that the association is an organizing member of, in many situations, we have that network has more Medicaid patients attributed to them than some of the health plans have members in Medicaid. And then whenever you expand that beyond Medicaid, which is outside the scope of this committee, understandably, But when you expand it to the total breadth of patients that are receiving care by these members, it does create some interesting scenarios. And I get struck by the adage that if everything is the number one priority, then nothing is prioritized. And I think we need to find a healthier balance in trying to find what is the 1, 2, 3 things that we need to really work on, focus on, and then iterate as we move forward. So I'm happy to answer specific questions from the committee to delve deeper into any of these particular kind of topics that I had mentioned, but before kind of assuming that I know what the committee members want to hear, I mean, pause to see if there are any questions.
Did anyone have any questions on that? I'm not seeing anything. So Dr. Hoagland, can you frame that language in a way that we can maybe get have a motion to make a recommendation?
Mr. Chair, I will do my best. And I might suggest if you consider potentially 2 recommendations. One would be a recommendation that the department, managed care organizations, and interested provider groups work together to identify an enhanced process to track eligibility and enrollment information through to the provider so that the information has the opportunity to flow more seamlessly and be used to help engage and contact patients. Would be one. And I don't know if you want to do the second or pause for.
Any questions on that?
So if somebody could make a motion, and then you can vote on that recommendation.
I move to adopt the motion as outlined by Dr. Hoagland.
This is
Thank you.
Patrick. I'll second that, John.
Thank you, Patrick. All those in favor?
Aye.
Aye.
Any opposed? Okay, thank you. So that was that was just the first one.
Correct.
You have a second one? Okay.
The second one, there is some narrative described here. I might recommend some amendments to this that for your consideration. Obviously, it's your decisioning. But we would, I think, a recommendation could be that the department, the managed care organizations, and interested providers develop a work group to explore opportunities to streamline the value-based program that would include operational efficiencies and common reporting, et cetera. So basically just to gain more uniformity in the value-based program that providers are operating under.
Okay. May I have a motion?
John, I'll make the motion, this is Dennis, for the framework that Dr. Hoagland had just explained.
Thank you, Dennis. A second, please.
This is Patrick. John, I'll second that.
Thank you, Patrick. All those in favor?
Aye.
Aye.
Any opposed? Okay, and the motion carries then.
Dr. Hoagland? I'm
Yes.
sorry, John.
That's
This is
okay.
Erin with the Department of Medicaid. I had received your recommendation in writing along with the agenda. If you'd like, I can send that back to you so you can tweak it and then add the other recommendation in writing for me. Would that work?
Yes, that'd be fine. Thank you.
Thank you. And also I wanted to let you know Justin Derringer from our department, Department of Policy is on and can address 4A if you guys would like to go back to old business.
Okay, thank you. Thank you, Aaron. Let's see, what else do we have on the agenda here? Dr. Holden, did you just cover 1 and 2?
Yes, I believe we did.
It looks like you did, yeah. Okay. So then let's go back to, thank you, Dr. Hoagland. Let's go back to 4A then.
Hi, my name is Justin Derringer. I'm with the Division of Healthcare Policy. So all of our procedure codes on the physician's fee schedule and our other fee schedules that have recently been updated for fee for service, there's no impact to what you all need to do for reprocessing. On the fee for service side, those are all reprocessed automatically for you all. So you all will get that through the system, will be done. You all don't have to touch it, don't have to do anything. We do that automatically, backdating to January 1st of 2025. I know several of the managed care organizations do that as well. I know there are a few that have some other processes that you all have to follow depending on which managed care organization it is. But that's how we do that on the fee for service side. Is there any other specific questions about that process for our fee schedules? We do have a few fee schedules that aren't currently out yet. But physicians and podiatry, all those are out.
Any questions? Okay, Justin, thank you very much for that.
Yes, sir. Thank you.
Appreciate it. Appreciate it. Okay, then that moves us on to DMS updates.
Hi, it's Veronica again. I don't think we have anybody else on to provide the 1115 waiver application in that subject matter area, but I can give an update. We, as folks may remember, House Bill 695 that was passed in the last General Assembly session required the department to submit a community engagement 1115 waiver. And there were some very specific components to that the department was required to incorporate into that waiver. We did quickly, and we had to do that in 90 days. And that 90-day ended yesterday. So in case anybody is just really needing to, I don't want to keep people on suspense. We did submit it yesterday. So it did get to CMS, Centers for Medicare and Medicaid Services. We posted that, that information is still out on our website. We did the required 30-day posting. That closed a couple weeks ago. We had some great comments. So we did make a few tweaks based on those comments, and we will be we've addressed those comments in the updated version, and that will be posted so people see that we reviewed those and took them into consideration, and provide a response if applicable. What happens now is that it was submitted to CMS. They can basically take about as long as they want on approval. And we do believe that this is going to get caught up in what's happening at the federal level. There is currently in the the budget reconciliation that is happening at the U.S. House of Representatives and the U.S. Senate. They are in conversations about some pretty major changes to Medicaid, and one of those includes a community engagement or work requirement. So that would very much take precedence over and priority over what the state's going to do. So we do wonder if CMS will hold it until that has been resolved in some kind of final federal law. So that may impact approval of this, but we will keep folks updated. But it's going to be pending, and so there's probably not going to be much of an update until we get something back from CMF. I'm happy to answer any questions about the waiver. Okay.
I'm not seeing any questions on that. And then there was, well, you may have covered that too. Update on federal changes. I think you.
Yeah, you know, the best that we can say to people is it changes daily.
Mhm.
So, you know, we had the House version, now we have a Senate version, and just in the last couple of days, the parliamentarian has been reviewing it to ensure compliance with other rules. And so the parliamentarian has said that there are some things they can't implement through the reconciliation. So I just, you know, really all we can say right now is we are closely monitoring it. We are trying to prepare fiscal estimates as things get sort of passed within a proposal. But right now we're just telling folks, we just have to wait. We have to wait to see what's the final, what comes out is final. And once that happens, the department will be communicating with members and providers and other interested parties, advocates about what is the real impact to Kentucky Medicaid. There are some provisions that don't impact us at all. And because they're directed at other states who have done other things. But once we get something final, we'll definitely communicate that out.
Thank you. It seems like a moving target. I mean, it's
Very much, very much. And we understand it causes a lot of anxiety. And it's really hard not to be able to give people some reassurance on what's happening. But the best we can tell folks is, you know, we'll communicate when we have an understanding of what is going to truly impact the program.
okay. Appreciate that. Thank you, Veronica.
You're welcome.
Thank you. Let's see, what do we have next here? Let's see, that was the DMS, DPH rep updates.
I think I saw Dr. White on. There we go.
I am here and I do apologize. I am not sure if we had an assignment for this or if this is just our place on the agenda. Okay. All right. Thank you. We continue to work with the moving targets that you're talking about. We just got a letter from Molly Lewis about writing a letter of support for them for their maternal work that they're doing. And we are obviously concerned about services to our pregnant and parenting women, and we'll be working with them. I'll be going to their annual meeting. I'm excited about. We are have received a grant from HRSA where we will be starting a not a postpartum, I'm sorry, a perinatal mood disorder consultation line. This will allow providers, and I'm a retired OBGYN physician, so I understand this situation. When a patient walks in your office, either while pregnant or in the postpartum period, and you know something's not right and you are not feeling equipped to address that, this consultation line will allow you to have a consult with a perinatal psychiatrist. So you can say, you know, Mary Lou came in the office and this is what's happening and I'm not sure what to do. So this consultation line will be have two prongs to it. That perinatal mood disorder specialist will then call me as the provider and help me figure out what that treatment plan should be. And then we will also ask that patient, are you agreeable to let someone from our staff contact you? And we will have an outreach person that can help connect them to who's available in the community that can take your insurance, that can help you with counseling if that's what you need. Are there support groups in your community? Is there if there's not, is there an online support group that meets regularly? Are you part of your postpartum depression is because you were stressed because you need housing, food, diapers. So it's a way to help the provider be able to provide the best care that these women need, and then a way for us to do some outreach to the patient to be sure that they are aware of all the resources in their community. So we're hoping, fingers and toes crossed, this will launch in October as long as our funding continues. And so we will be rolling this out, and I would hope that when we do get something that we can actually roll out, that this group would allow us to come and present to you, because we need this not only in the hands of our OB doctors, we need our pediatricians to know about this, because they're the ones that see the patients more postpartum than I would as an OB provider. So when mom comes in with the baby, there may be something that's noticed, and they need to know that they have this consultation line, or that family practice doc that sees that postpartum patient at 5 months postpartum, and she's having headaches and backaches and she can't sleep. And it's like, oh, this is very likely a postpartum depression. Yikes. Now what do I do? There's a number they can call to be sure they are providing the best care to all of their patients. So this is not just for Medicaid patients, this is for statewide. So that's the thing. And again, as an OB doc, that's the thing that I'm most excited about sharing with you. And we would love to come back and present to this group at that time. Any other questions that you have for me? There's so many things going on in our department. I really even know where to start. I know y'all saw our recent HON about the measles, I'm sorry, whooping cough deaths. We haven't had any new measles cases, so that's exciting. But what questions can I answer that anybody on the screen might have? Public health. I'm not the subject matter expert, but I know them, so I can find them if you have something that I can't answer.
I'm not seeing any questions, but we would be looking forward to updates on that program. That sounds
Yes,
exciting.
And at noon today, another new exciting thing, I'm not sure if Veronica knows about this, Dr. Terrio, I saw her somewhere. Dr. Terrio is the medical director for Medicaid. Dr. Henrietta Bada is the Title V director, and I'm the medical advisor for the Perinatal Quality Collaborative. We applied to the National, help me, NASHP, National Academy of State Health Policy. I think I got that right. It's a learning academy to look at maternity deserts. And so we're going to be working with 7 other states and NASHP in a learning collaborative of how can, I mean, other than building a labor and delivery hospital in every county in Kentucky, which isn't going to happen, what can we do with what we have to try to improve the care of these women? So we're starting today at noon. So I'll have an update on that a little bit later too. But right now, all I can say is we're meeting at noon today, and we're extremely excited about this opportunity.
Okay. Thank you very much, Dr. White. Appreciate it.
Thank you.
Excuse me. Appreciate that. Okay. Let's see. DBH DID update.
Good morning. My name is Ann Holland. I'm an executive advisor within the Department for Behavioral Health, Developmental, and Intellectual Disabilities. And today I'm going to talk to you all about a new Medicaid benefit for persons with serious mental illness. If you'll give me a second, I've got a presentation to give you all. Let's see. Tell me when you see, do you see it yet? No, hang on.
Not yet.
How about now?
There you go.
Okay. I'm a little technically challenged, so just bear with me. But as I said, my name's Ann Holland. I'm the executive advisor within the department, and I am the 1915I RISE Initiative lead for our department. Okay. So, based on a Senate Joint Resolution 72, the legislator asked CHFS to create a Medicaid program to address needs for individuals with serious mental illness. I may also say SMI, but that stands for serious mental illness. And so together, DMS in partnership with DBH and collaborations with the rest of our cabinet, we applied for a 1915I state plan home and community-based program amendment and was recently approved in the end of March. And so what does that mean? So 1915I state plan amendments allow a state to define a target population to serve. You can define the ongoing supports and services to be included in that benefit. You set the eligibility criteria, and the individual does not have to meet institutional level of care like the 1915C waivers. That level of care is institutional. This is based on need. So there is no slots like there is with our 1915C waiver. If the individual meets criteria, they receive the benefit if they choose to take the benefit. So what is the 1915I RISE initiative? As I said, it's a new benefit under the 1915I state plan amendment. This is the first 1915I that our state has applied and got approved for. It is home and community based. There are some federal requirements, the same as 1915Cs, such as it has to have conflict-free case management, federal setting rules, and then there's also an independent assessment for that eligibility determination. So what are the RISE 1959 RISE principles? Recovery, independence, support, and engagement. Its initiatives focus on helping individuals rise above their challenges through services that promote recovery, independence, and community engagement. Who qualifies for this benefit? So the 1915I RISE initiative was developed around the identified needs of individuals 18 years of age or older with a primary diagnosis of serious mental illness or primary SMI and co-occurring substance use disorder addiction. In addition to this diagnosis criteria, individuals must be Medicaid eligible with a 150% or below federal poverty level and will be assessed by an independent assessor to determine if they show clear evidence of functional need in at least 2 defined functional need domains. We have some housing services in this benefit package, and in order to be eligible for those housing related services, the participant must show evidence of one or more of the following risk factors: be homeless, at risk of homelessness, history of frequent stays in inpatient setting or a nursing facility, or was homeless in the prior 24 months, or formerly homeless, now residing in a HUD assisted housing. And so this benefit package has 10 services in it. And I'm just going to briefly go over these 10 services. And so the first one you see here is supervised residential care. This is similar to the residential care that 1915C waivers may have. This is for 3 people in a home, an agency-owned home. And it's up to 24 hours of supervision in the agency-owned home, but where the person must be homeless or at risk of homelessness, those features that I spoke of previously. If the person chooses to may start in this level of care, but they want to be able to work towards independent living, they will be able to start working towards that goal within this highest level setting of service. We also have what's called in-home independent living supports, and this is support to an individual to enable their ability to live independently. Goals and objectives for this development of requisite skills to maximize their own independence. So this service assists individuals who may have some needs with personal care, meal prep or shopping, education or budgeting, food safety, developing social skills, education on medication management, assisting with ranging transportation, or providing non-medical transportation for social events that the person may want to attend. Um, housing and tenancy supports. This is brand new. This is a new, some other states also offer this. This is based on the permanent supportive housing principles. This support can assist an individual with identifying and obtaining housing, assist with understanding leasing agreements, helping them obtain the necessary documents to apply for housing. To create a budget, like a house budget, and then once the housing's obtained, be able to follow them and assist them with maintaining that housing. I like to say, if they say need to develop a skill to learn to work with something with their landlord to advocate for themselves, this support can assist with that. We also have supported employment and supported education. These are both evidence-based practices. They're designed to assist them with obtaining a job with supported employment and maintaining that job, as well as within education to work towards an employment and maybe obtain a skill set, a degree even to obtain that job. Transportation, this is in addition to the individual's non-emergency medical transportation. This allows a small amount of money annually for them to be able to go to social events or to go shopping or to visit family or friends. It's not a huge benefit, but there is something that allows them to, engage in their community. We also have medication management, promotes adherence to medication treatment. We provide education on the medication purpose, the side effects of the med, and additional medical assessments as needed, and as part of that person-centered service plan that will be developed and we'll kind of talk about here in a few minutes. For individuals that have caregivers they live with, there's planned respite for that caregiver. This allows the caregiver to have a break from taking care of that individual and promotes community building, natural supports, and prevention of institutionalization. Assistive technology. This would help and assist with providing equipment, software, or products that improve functional capabilities to support individuals' ability to maintain community living, education, and employment needs. And then I like to say the linchpin of all of this, and I kind of joke and say Oprah gives away cars, but the 1915 I is going to give away a case manager. Every individual that approves this benefit or accepts to take this benefit will have an independent case manager who helps them drive their services. That person helps them with, identifying, taking the assessment and saying, these are the needs that are identified, and here are providers who can provide these services for you, and assist them with obtaining those providers, and then ensuring on an ongoing basis that those services are meeting the goals and objectives that were set forth in that person-centered service plan, and assist with any new needed resource or address any need that it comes up and is identified throughout the process or as the person goes on. So this is as I said, a new covered benefit. It offers flexibility to what services an agency may choose to provide. This is, a plug for people who may want to provide these services. Like the 1915C providers, we have a certification process. It will be done by the Department for Behavioral Health, Developmental, and Intellectual Disabilities prior to Medicaid enrollment. We've completed our steps for getting certification. We are launching this July 1st, which is just around the corner. We're going to have, we've got some social media blasts going out this week, next week, and the following week. In about mid-July, we're going to host a sort of a town hall webinar for anybody and everybody to come and learn more in depth about the certification process and enrolling, and more in depth about what the journey is for an individual. One of the things that DBHDID 1915 I staff will do is, with providers, not only do we certify them, but we will continue to provide technical assistance to them and monitor for compliance, and offer continuing education opportunities to providers and their staff. We have a couple of things. Check out our website. It's dbhdid.ky.gov 1915 I-RISE initiative. I do know that I think Aaron's going to send these out when this is over. These slides will be given to you all. Anyone that's interested in being a provider, we have an email address for that. It is a new provider type within Medicaid. It's a provider type 51, and it's called, I think, 1915 I-RISE. Even existing providers that want to provide these services will have to be certified by our department and enrolled in this new provider type to do this. It is a fee for service that does not involve the managed care organizations, like our 1915C and nursing facility enrollees. This is also falls into that bucket of traditional Medicaid and fee for service programming. Then, like I said, 1915 I-RISE provider at ky.gov is for providers, and then we have one for participants as well. And then here, the last email is my contact information. Any questions? I'll be happy to answer, and if I can't answer them, I will get back to you. I will get the answer and get back to you. Let me stop sharing. Okay. Well, thank you.
I'm not seeing any questions.
If something comes up later, you will have my contact information. Feel free to email me at any time.
Okay.
Thank you all again for letting me present on behalf of the Department for Behavioral Health, Developmental, and Intellectual Disabilities.
Thank you we appreciate that presentation. Thank you so much.
Thank you, Ann.
Thank you very much. Okay, do we have any other business from committee members? Anything that we don't have on our agenda? Okay, I'm hearing silence. So with that, may we have a motion to adjourn?
So moved.
Second.
Okay, all those in favor?
Aye.
Aye.
Okay, motion carries. Thank you all very much for attending this morning. We appreciate it.
Thank
You all
you.
have a good rest of your day.
Thank you,
Thank you,
John. Thank you,
John.
everyone.
Thanks, everyone.
Thanks. Have a wonderful day.
Thank you, you too.